This conference will now be recorded.
Okay, so we'll be starting a new chapter today, and that is the surgeon's spleen. And why did I name this as a surgeon's spleen? Because we as surgeons have got an absolutely different kind of a role to play when we are talking about splenic pathologies as compared to the physicians. Just a few acknowledgements and reference books that you can consult if you want to study more about the spleen. Now, coming to the embryology of the spleen, it is basically a mesodermal organ, and if you look at the mesoderm, this is the initial embryonal stage, and you got the stomach out here, you got the midline, the two kidneys on either side, and this is the dorsal mesogastrium. Now, if you have the dorsal side of the mesogastrium, here you have the spleen. So it's got on the left leaf of the mesogastrium. It's on the left leaf of the mesogastrium, and this is the stomach out here. Behind you got the kidneys. Now, as time passes, there is a rotation, and the stomach rotates to the left side, because of which the spleen also shifts, and it takes the spleen along with it to the left upper abdomen. And when it's doing so, it drags the splenic artery along with it. So the splenic artery is being dragged there, and the surface of the mesogastrium fuses with the peritoneum over the kidney. Now, let me show what I mean. You see this layer of the mesogastrium left side, and you see the parietal peritoneum. So when it is going to rotate to the left side, these two layers will fuse together, and that is what is shown out here. So when they fuse together, they form the lower leaf of the lienorenal ligament. These are the fused parts of the dorsal mesogastrium, the left side, and the parietal peritoneum. And this is the right side of the right side of the dorsal mesogastrium that remains separate. So that is how the lienorenal ligament is formed by the fusion. So the undersurface formed by the fusion of the two layers. Okay. Now the proximal part of the same dorsal ligament remains as the connection between the stomach and the spleen as the gastrosplenic ligament. Now, you can find agenesis in 10% of children, and they usually have congenital heart disease. Spleniculi, which is an accessory spleen, is found in 10 to 30% of cases, which is basically quite a high percentage. And when you find these, they can be as large as 3 centimeters in diameter. 50% of them are usually housed at the hilum. So this is the most common site where you find the accessory spleens. The next are the splenic vessels and the tail of the pancreas. So this is the second site where you'll commonly find it. So apart from these two sites, which account for almost 80% of accessory spleens, the rest of them would be found in the various splenic ligaments or the mesocolon. Now, coming to the anatomy, and you have to remember the odd numbers. Remember 1, 3, 5, 7, 9, and 11. I hope you are remembering this from your knowledge of anatomy or lectures of anatomy. And 1, 3, 5 are denoting the size in inches. The weight 7 is in ounces, which roughly translates into 150 grams in metric units. It's situated between the 9th and the 11th rib. See the situation, the 9th and the 11th rib, and the long axis is along the 10th rib. So that accounts for 1, 3, 5, 7, 9, and 11. It has got two surfaces, one which is in contact with the ribs, which we know as the diaphragmatic, and the one which is in contact with the various organs inside the abdomen, which we know as the visceral surface. Now, all this is important. This I am spending some time on this part of the anatomy because the commonest area in which we surgeons are involved is in managing the splenic trauma or doing something to the spleen in the form of splenectomy, either as a part or as a total procedure. Now, when we're doing that, we have to understand the anatomy and the relations very, very clearly. Now, coming to the relations, if you look at the lateral relations, we already said lying between the 9th and the 11th rib, and the long axis along the 10th rib, right? Now, lateral to it is lying the diaphragm, and just behind the diaphragm, you've got the costophrenic angle of the left side. And beyond that, you got the parietal pleura. So the parietal pleura, the costophrenic angle, the lower angle of the lung, the diaphragm, and the parietal wall, they are all in lateral relationship to the spleen. The reason why this is important is if there's any kind of trauma in this particular area, is going to damage your parietal wall, it may damage the lung, it may damage the parietal pleura, and then it will go and damage the spleen. When you come to the visceral side, it has got clear-cut impressions, and the impressions are resembling, number one, the renal impression here, which is below the hilum. Above the hilum, you got the large gastric impression, and below you got the colic impression. So three important impressions: the lower one or below the ligament, the kidney and the adrenals. Above you got the stomach, and here you got the colic impression. The notch is very, very typical, which is found on the upper or the superior surface, or you can call the medial surface when you reflect the spleen towards in its normal position. So on the medial aspect, you got the typical notch there. And at the hilum, we got the ligamentous attachment in two layers, and that layer encloses the splenic vessels, right? The lesser extremity, the lesser sac, is also in close relationship, and the pancreas are relationship in the hilar region. So the organs are beyond or away from the hilum, and inside the hilum you got a relationship of the lesser sac and the pancreas. Okay. Now this shows a better representation. See the tail of the pancreas coming in relationship with the hilum. That's how it's related. You can see the kidney related to the undersurface of the medial to the hilum here, or posterior to the hilum, you can call it. Here is the stomach. The stomach has been reflected up or been shifted up. So here you'll find the stomach, and here you can find the colon. See the excuse me, the splenic flexure of the colon, which is again in relationship to the spleen. So these are the relations of the hilum, of the spleen and the visceral surface. A point to be noted at this point of time is that the pancreatic tail and relationship to the spleen is very, very important. Why? Because in various degrees of pancreatectomies, in various kinds of splenectomies, you have to be very, very careful that you don't damage the spleen in one case or the tail of the pancreas the other case. For that, you have to remember that the pancreatic tail, it abuts the hilum in 30%. That means this is abutting the hilum 30%, while this is basically stopping short of the hilum, which is a much more common scenario in 70%. So it will be within 1 centimeter of the hilum in 70%, and in 30% it is going into the hilum or abutting the hilum. And it is important that you have to ligate the splenic vessels within 1 centimeter for the hilum to avoid injury to the tail of the pancreas. That means if you start ligating the vessels here in this region, you're most likely to injure the tail of the pancreas, and injuring the tail of the pancreas can always lead to a post-operative pancreatitis. So remember, that is the applied importance of the abutment of the pancreas, the pattern abutment of the pancreas to the splenic hilum. Now coming to the ligaments and attachments, there are two true ligaments. Number one is the gastrosplenic, we already referred to, and the splenic pedicle and the lieno-renal ligament. Lieno-renal ligament is basically from where you have the entry of the vessels, the splenic vessels, and you got the gastrosplenic ligament. The other two that you have to remember are attachments. They are not real ligaments. One which is attaching the spleen to the diaphragm, under the diaphragm. This is the splenophrenic ligament. You call it a ligament or attachment. And the other is what is attaching it to the colon, known as splenocolic ligament or splenocolic attachment. Right now, this splenophrenic ligament could be quite extensive up to the superior surface and even up to the lateral surface, even lower down. But splenocolic is basically the attachment which is only to the colon. Now, these two are those attachments where they are avascular. There's no, so if you're going ahead and doing a splenectomy, to say that I don't expect any vessels inside these two, so let me cut them with abandon. May be true, but remember, when you have a portal hypertension patient with a lot of collateral circulation, there would be vessels in these two ligaments. So remember, otherwise in a normal circumstance, these two are avascular ligaments, but otherwise in a patient with portal hypertension, they become vascular, and that's why if you're doing a splenectomy in a patient with portal hypertension, for whatever reason, we are not talking about the reasons right now, for whatever reason, you have to be very, very careful. Why? Because there will be a number of collateral in that particular area. The gastrosplenic ligament is important. Why? Because you got the two terminal branches of the splenic artery, which are there, which are very important. Why? They're supplying the whole of the greater curvature of the stomach namely the short gastric vessel supplying the superior aspect of the greater curvature, and left gastroepiploic supplying the inferior aspect of the greater curvature. The splenorenal ligament, I told you, is important. Why? Because it's got the splenic artery, the vein, and it has got the tail of the pancreas. It's got the tail of the pancreas. So all these vessels, tail of pancreas, are all their splenorenal ligaments. So remember, these are the 4 ligaments and 2 attachments that you have to remember. Now coming to the splenic artery. If you come to the splenic artery, it is the largest branch from the celiac trunk. So this is the celiac artery, this is the aorta, the celiac artery, and you've got the splenic artery which descends down and then comes along with the superior or just behind the superior aspect of the body and the tail of the pancreas when it again ascends up to the hilum. So it has got 2 curvatures. One, it is descending down and then it's ascending up. Now in its course from its origin from the celiac trunk until it reaches the superior border of the pancreas, it is going to cross the left crus of the diaphragm, which is somewhere here, left crus of the diaphragm. Adjacent to it, here you will have the psoas muscle, and then along the superior border of the pancreas. So it is going to cross the left crus, is going to cross the psoas, then travel along the upper border, ascending up, and then entering into the hilum of the spleen. Right now, there may be an aberrant origin of the celiac trunk, which could either be arising from the common hepatic, that could be one, or it could be arising from the left gastric artery. But whatever the origin, the most common is the celiac trunk, and it is lying at the level of T12 vertebrae. Right. The other alternate sites from where the celiac trunk could be arising is from the aorta directly, or the splenic artery. Sorry, the splenic artery arising could be direct from the aorta and the superior mesenteric artery. The superior mesenteric artery is somewhere here. So this artery, instead of arising from here, the splenic artery could be arising from this place, or it could be a direct tributary of the aorta. Now, when this splenic artery is traversing from its origin up to its destination, it gives rise to proximal branches here and distal branches. The proximal branches are important. Why? Because these are the pancreatic branches, and among the pancreatic branches, you've got the 3 important pancreatic branches. Number 1 is the dorsal pancreatic branch. The dorsal pancreatic branch descending behind the pancreas. That's why dorsal pancreatic branch. Then you got the inferior pancreatic artery. The inferior pancreatic artery, which is a branch of the dorsal pancreatic artery. Then you got the greater pancreatic artery. This is the greater pancreatic artery, and artery to the tail of the pancreas. So 4 important pancreatic. Apart from that, there could be other unnamed pancreatic branches. Like, see, these are small branches which could well be arising, and that's why is it important? It is basically important that if you're going for any kind of pancreatectomy, you have to devascularize the pancreas, and you cannot just say that I have ligated the 3 important branches and now I'm done with, and I can straight away go and do a pancreatectomy. No, absolutely not. There are multiple small supplies from the splenic artery to the pancreas, and each one of them has to be dealt with. That's why the operation of pancreatectomy is so difficult. The vascularity is the major problem. So apart from these 4 important ones, or rather let's say the 3 important ones, the dorsal pancreatic, then you got the inferior pancreatic, and you got the greater pancreatic artery and the pancreatic branches. Apart from that, you can have multiple branches in this particular area, and then to the tail of the pancreas. So this is the proximal part of the splenic artery. Now coming to the distal part of the splenic artery. Now when you come to the distal part of the splenic artery, we are talking about this particular area. And when you look at this particular area, you're basically talking about the 2 terminal branches being supplied to the stomach. Remember, I told you the short gastric vessel and the left gastroepiploic vessel. There's the short gastric and the left gastroepiploic vessel, 2. And number 2, we are talking about the terminal splenic branches. Now, the terminal splenic branches are about 5 to 6. 2 of them are polar arteries supplying the superior pole and the inferior pole, and routinely you've got 3 important branches supplying the hilum, directly entering into the hilum. So the ends of the hilum, the superior polar, the inferior polar, and you've got the 3 important branches, the superior, middle, and inferior terminal splenic artery. So normally the spleen is supplied by either 4 or 5 vessels, or maybe even 6. Now, the things to remember is that when this splenic artery terminates in the spleen, there are two patterns of termination. Now see this pattern. Can you see the pattern here? The branching has started almost 1 to 2 centimeters before the hilum. See multiple branches coming out here. And here, see what has happened. This is a more terminal branching. So the first one, this type of branching is known as a distributed splenic artery branching. And this is known as a magistral splenic artery branching. The applied importance is very obvious. And what is the applied importance? The applied importance is that when you're doing a splenectomy, you have to be very, very careful if you have a splenic artery with a distributed pattern, as opposed to when you have a splenic artery in a magistral fashion. Why? Because here, see, just ligating here would be sufficing. You're just ligating one branch, one terminal branch. But here, you can't afford to ligate the splenic artery here. You're going to devascularize, the chance of devascularization rests the pancreas. So you have to ligate each one of them separately. And that's why trying to devascularize the spleen in a splenic artery with distributed splenic artery is slightly more difficult as compared to the magistral pattern of distribution. One. Number two, there are often short circuiting between the splenic and the short gastric. See, this is short gastric out here. This is a polar branch and this is the terminal branch, and you can see the anastomosis. So transverse anastomosis are also important. Why? Because they have to be taken care of when you're trying to devascularize the spleen completely. That brings us to the terminal branches, and these were the short gastric, the left gastroepiploic, see very clearly out here. The left and the right anastomosing out here. The right one is a branch of the gastroduodenal, the short gastric vessels out here. And I told you that the intrasplenic branches, they do not communicate with each other. So there is a relatively avascular plane perpendicular to the long axis of the spleen. So what I'm trying to say is that when these are supplying the spleen, there are areas which may be clearly demarcated, and there is no anastomosis between these areas. And that is why you can hope to do a partial splenectomy without too much bleeding. So relative avascular, it's not completely avascular, relative, because the pattern of anastomosis between these branches inside the spleen is not very formidable. It is not very confluent. So you have minimal amount of connection between these branches intrasplenically. Okay. So 20%, there are 3 terminal branches and 3 corresponding segments. So you got the 3 corresponding segments of the spleen: the upper, 1 segment, 2 segment, and 3. So upper pole, middle pole, and lower pole. That is the pattern in 20%. You can have even more in other patterns, right? Now coming to the splenic vein, and the splenic vein are the formative tributaries which accompanying the splenic artery. They form the splenic vein, and from there you again receive the corresponding veins, that means the gastroepiploic, the short gastric, and ultimately you form the splenic vein, which is more posteriorly and inferiorly situated than the splenic artery. See the figure? It is more posteriorly situated. The splenic artery is somewhere here. The vein is slightly more posterior, right? Until it joins with the inferior mesenteric vein to form the portal vein, or with the superior mesenteric vein to form the portal vein. So the splenic vein is a tributary which opens into the inferior mesenteric vein, and that inferior mesenteric vein along the splenic vein then opens into to form the portal vein along with the superior mesenteric vein. That part I think is clear. Now come to the microscopic structure of the spleen, which is again important for reason I'll just be telling you, and it has got 2 coats to it. One is the external serosal, which is the visceral peritoneum. Every organ which is intra-abdominal has got a visceral peritoneum, and the inner fibroelastic coat is important. Now if you look at this, this is the fibroelastic coat. This is the capsule, made up of what? Made up of collagenous tissue. It's got collagenous tissue, right? Without any muscular fiber. There are no muscle fibers here. And this coat is going to send trabecules. See these ingrowths? These are the trabecules inside, in which are lying what? A tributary of the splenic artery, a tributary of the splenic vein, a lymphatic, which is the efferent lymphatic, and a nerve. So the capsule, which is made up of collagen without any muscle, sends in trabeculae inside the pulp of the spleen, and in these trabeculae are lying the vasculature, the vessels, the lymphatics, and the nerve. Now, the size of the spleen increasing or decreasing is not because of any muscular fibers in the capsule. If they were, then that would have been responsible for the contraction of the spleen or expansion of the spleen. Instead, what contracts and expands the spleen is the contraction and relaxation of the blood vessels consequent to the alteration of the blood content. Okay, so the size of the spleen varies depending upon the amount of blood. This is a short term, we're talking short term, not long term. Short term size decrease and increase is because of either dilatation or contraction of the vessels. Long term would be infiltrative, we'll come to that later. So the collagen capsule does not have any muscle fiber. Now that brings us to the second component of the spleen. Apart from the coat, there's a collagenous coat, and there is a splenic substance, and the splenic substance got three specific substances to it: the white pulp, the red pulp, and the marginal pulp. We'll just talk about that in a short while, right? Apart from that, you got the vasculature in the trabeculae, that is the splenic artery and vein. You got the lymphatics. Now see, this is very important and in bold. There are no afferent lymphatic. No lymphatics enter the spleen. No lymphatics enter the spleen. They only exit the spleen. So efferent lymphatics are present. Afferent lymphatics are never present in the spleen. There is no lymphatic sinus system inside the spleen, and there is no cortex or medulla inside the spleen. And that is why, because we say that spleen is akin to a lymph node, but the difference, why? Because both are parts of the reticular endothelial system of the abdomen. But the lymph node and spleen differ in this, that there is no afferent lymphatic, the lymph node has it. There is no lymphatic sinus system, the lymph node has it. There is no cortex or medulla, the lymph node has it. Efferent lymphatics are there even in the spleen and the lymph node. And the efferent lymphatics from the spleen, they ultimately go and drain into the celiac group of lymph nodes. The nerve supply to the spleen is through the sympathetic celiac plexus, which is supplied by the splanchnic nerves, and you got the vagus, which is supplying the parasympathetic supply to it. Right? Now, coming to the white pulp and the red pulp and the marginal. This is important, so you should remember what we are talking about. Now, when the splenic artery is entering, see, this is the arteriole. When it enters into the spleen from the trabeculae, it gets a coat, and that coat is basically a coat which is known as the periarteriolar lymphatic sheath, or PAL. So it is coated by a lymphatic sheath, right? Now, this lymphatic sheath is concentrated at places to give rise to what is known as lymphoid follicles. So the PAL has got the splenic lymphatic follicles known as the Malpighian bodies and the periarteriolar lymphatic sheath. The periarteriolar lymphatic sheath is the site where you have the maximum number of T cells. So these green ones are the areas where you have maximum number of T cells, while the lymphatic follicle or the Malpighian body is the site where you've got the maximum B lymphocyte production, right? Now, there are no lymphatics, so how would these lymphocytes which are being produced, they are going to enter the circulation? That is basically by an amoeboid movement, and they enter into the red pulp. Now, once this trabecular artery with the PAL, that is the periarteriolar lymphatic sheath, exits the sheath, there is an area where it is absolutely free. That means it does not have any sheath. About 0.5 millimeters or 1 centimeter, that part is known as what is known as a peniculi. That part is known as a peniculi. Sorry, that is part. So this straight part is the penicular part. Now, once it goes into the red pulp, it now gets an other sheath, and that is now a periarteriolar macrophage sheath. This is known as the ellipsoid. So you got the straight part of the artery, which has got the lymphatic sheath. Then you got the straight part of the artery, or branching part, which has got no sheath, known as the penicilli. And then you've got the sheath of the macrophages, which is known as the ellipsoid. Now, once it exits the ellipsoid, which is the periarticular macrophage sheath. When it exists the ellipsoid, it can have two kinds. One, it can enter directly in communication with the sinus. See this communication? That is the direct communication. The second is it is going to open up freely into the red pulp, discharging all its blood and contents of red pulp. And from the red pulp, the blood then seeps back into sinus. So this is basically a closed system. Why? The blood has never come in contact in actuality with the pulp of the spleen. Has it? No, it is lying inside the vessel here, lying inside the vessel here, lying inside the vessel here until it reaches the sinus. It has never come in contact with any part of the pulp. But here what has happened? The artery has truncated here, and after the truncation, it has discharged its contents into the red pulp. So it has now become an open discharge, and from there then it seeps back into the sinus. That's why this is known as a open circulation. The ellipsoid part, which we just said, it is coated by macrophages. Along with that, it also has other important cells, namely the dendritic cells, and we all know the dendritic cells are basically the APCs, or antigen presenting cells. And it has got specialized B cells which are migrated from here, and they are known as marginal B cells out here, right? And this marginal area is known as the marginal zone. And this is a zone located between the red pulp here and the white pulp here. So this is the marginal zone we're talking about, right? So now we know what the closed and the open circulation means. Now, once it is discharged its contents into the pulp, it is the red pulp. And that red pulp constitutes 75% of the spleen. So remember, the red pulp is 75%, the rest 25 is the white pulp and the marginal. So that basically tells us that most of the spleen is made up of tissue which is red pulp, rich in RBCs, platelets, and like cells. What does this red pulp contain? It contains, number one, splenic cords of cells along what? Along a reticular meshwork. This same trabecule has given out a reticular meshwork. And that reticular meshwork is now filled with blood, which had been discharged in an open fashion. And this blood which is lying inside the reticular meshwork, which is lined by cells, which cells? The RBCs, the platelets, the macrophages, reticular, lymphocytes, etc., etc., etc. And the cell is bathing these cells. And from these cells, when it's bathing these cells are carrying out their function on that blood. We'll come to that function. They carry out their function on the blood. And now once the function is complete, now the blood will go back into the splenic sinusoids, right? So the red pulp is made up of the terminal parts of the vessels. It is made up of the splenic cords, and it is made up of the cells inside the cords, and it is made up of the splenic sinusoids, right? Now, what is this sinusoid all about? We talk about a splenic sinusoid. Now, this is how it looks like. See the open circulation, truncated vessel, the blood lying in the open space. Here, see direct communication with the sinusoid. Closed circulation, closed, open. Now, what are these sinusoids? These are basically blood-filled long vessels or spaces which are lined with fenestrated ring-like barrel loops. So these are all fenestrations. Why are the fenestrations important? Because they have to allow the RBCs to come inside. And when the RBCs have to come inside, they have to alter their shape along to the fenestration. And which RBC cannot alter its shape? RBC which is diseased. And that is why this forms a very good filter for diseased RBCs. Diseased RBCs, rigid RBCs, deformed RBCs like spherocyte, erythrocyte, they can never go inside the fenestrations. They can never enter the sinusoid. They would be just sequestrated or filtered off into the red pulp, right? Now, this lining of fenestrated lining has got cells to it, and these are known as the endothelial cells, and there is no connection between two endothelial cells. That means what we are saying is that there is a fenestrated lining, and on that you got cells which are distributed randomly. No connection between each other. They do lie side by side, but no connection, right? Now, macrophages are found in the cords and around the sinusoid. You have the macrophages here in the cords, around the sinusoids, and these are basically responsible for keeping or taking care of the deformed RBCs which have been filtered in the particular area. They will also capture the viruses, opsonize the pathogens which are entering the red pulp. So that is what the microscopic structure is all about. And based on that, we just now said that there are two kinds of circulation. Look, the 90% circulation is open type and it is a slow circulation. Why? Because the blood has to have some time inside the red pulp. It will be acted upon by the macrophages. Only then it will be allowed to go inside the sinusoid, excuse me. So it requires some time. So 30-60 minutes. The closed circulation, on the other hand, makes only 10% of circulation. It is a rapid circulation of 1 to 2 minutes. The slow circulation becomes increasingly important in splenomegaly. So you have to remember one thing, that when you've got a huge splenomegaly, the maximum, the major amount of circulation is open circulation, not the closed circulation, right? The blood flow to the spleen is 300 ml per minute. These are the half-lives which we have mentioned out here. You know about these half-lives. I'm not going to repeat them. Now, during the passage through the tubercular artery up to the sinusoid, the marginal sinus sinusoid, the blood, when it is coursing, it is being subjected to a number of changes. What are the changes? Phagocytosis of the particles, filtering of the plasma-rich blood, immunoglobulins and immune molecules, like for example, opsonins are added from the lymphatic nodule, immune cells are added, and during the passive RBCs, they have to alter their shape, and if they cannot alter it, they are distorted, they will get filtered out. Now, coming to the functions of spleen, the first and the most important, the immune function, represents, the spleen represents 25% of body lymphoid mass at puberty. See, 1/4 of the body lymphoid mass is spleen, a huge amount of lymphoid mass. Got two functions, immune function. Number one, synthetic. Number two, synthesis. Number two, phagocytosis. 66.5% of total body T cells are in the spleen. 10 to 15% of the total body B cells are in the spleen. They respond to the antigenic challenge by two methods. Number one, specific phagocytosis of the particle, bacteria, whatever is there, especially when it is coated with opsonins or antibodies. They clear the malignant cells. They are a major production site for specific IgMs. Non-specific action, immune action, relates to the production of opsonins, the tufstin, which binds to WBCs promoting phagocytosis, and the properdine system, which stimulate the complement by the alternate pathway. So this is the immune function. The other functions are, number one, pitting, which refers to repair of the surface abnormality, the RBC, like pits. Now, there are certain deformities in the RBC when the surface is dipped like a pit. So they are being repaired. If there's a spur along with the pit, that will be repaired. Culling or filtering is basically dealing with removing the damaged RBC. So this will only happen during open circulation. I just not told you that. So from the open end capillary is going to permeate, and it cannot enter the sinusoids. Because not enter the sinusoids, the RBCs will be destroyed. So abnormal RBCs like sickle cell, spherocytes, etc. would be filtered off. They would be retained back into the spleen. Aged RBCs more than 120 days, because they cannot alter the shape, would be retained back into the red pulp. Antiglobulin coated blood cells would be retained back into the blood, into the red pulp. They will not be allowed to enter into the sinusoid. What else? It is also going to remove the intracellular RBC inclusions, like high density proteins in cytoplasm, Howell-Jolly bodies, Heinz bodies, and Pappenheimer granule. So all this filtering of the cells and the subcellular particles is going to take place in the red pulp during the open circulation. It is also a reservoir, and that reservoir has to do with mainly a platelet reservoir. Now, under normal circumstances, it contains a normal pool of 1/3 of the total body platelet. In splenomegaly, it can have almost 80 to 90% of the body platelets inside the spleen. And see, if it's there inside the spleen, the patient obviously going to go into thrombocytopenia. It is also a reservoir of RBC, but that is a very, very minor function. So primarily it is the reservoir of the platelets. And then the final function, that is cytopoiesis, that means blood forming. And which part of the blood does it form? Now, hemopoiesis is an important function up to the 4 to 6 months of fetal life, up to 4 to 6 months, and that also occurs in the red pulp. But once the child is born, that function goes away. It is no longer a function of the spleen to make RBCs, except in special circumstances, like for example, a myelodysplastic syndrome or a stimulated body which has a dearth of RBCs and RBCs required from any source. There, the spleen can take over a minor function of hemopoiesis of RBC, WBC. Immune cell production, we already said, the Malpighian bodies, the B cells, and the T cells and lymphoid follicles, and the macrophages in the ellipsoids, right? Now, diagnostic considerations of the spleen. How do you diagnose a spleen disease? Number one, hematological is very, very important because that gives you an idea of the degree of vascular compromise related to the cells of the blood. That means the RBCs and the platelet. So doing a CBC, doing a platelet count and reticulocyte counts are all important indicators that there's something wrong going on in the spleen, or there is something abnormal in the function of spleen. Specific tests for hemolytic anemia may be indicated if you're suspecting a hemolytic anemia. We'll talk about that when we talk about the hemolytic anemia. Radiological imaging is important for we as surgeons. Number one, a plain skygram can show you calcification, and that calcification could be a solitary calcification, which is usually there when the patient has got arteriosclerosis splenic artery, or the patient has got an infarct in the spleen, or the patient may be having an old cyst in the spleen, especially a hydatid cyst, a parasitic or a protozoal cyst. These are those areas where you got a solitary calcification. You can have multiple calcification, which is a characteristic feature of a tuberculous spleen. You can do a diagnostic ultrasound, CT or MRI, and when are they indicated? For a macroscopic anatomical detailing. It tells you about the size, it tells you about the vessel, it tells you about the vascular pattern, it tells you about the space-lying lesions, so on and so forth. So you're trying to delineate the anatomy of the spleen. For splenic artery and vein delineation, like for example, the splenic artery has got aneurysm to it, that can be diagnosed on an MRA, the MRI angiogram, or a patient's got a splenic vein thrombosis that can easily be diagnosed on ultrasound, a CT or MRI. Or most importantly, for splenic trauma, a CT MRI or a CT is a must for diagnosing or for characterizing a splenic trauma. Radioisotopic imaging using 99 Hello. Hello.
Yes, sir.
I'm sorry, it was lost in between. Okay, so coming back. So we're talking about the splenic trauma, and this most important for us as surgeons. And we talk about the splenic trauma. They can be graded into 5 types, and I've drawn a figure for you. Grade 1 is a small subcapsular hematoma involving only less than 10% surface area, or a laceration less than 1 centimeter deep. So you can just read this up. I'm not going to waste time over this. So you got grade 1, grade 2, 3 are 2 types. In one, you've got a burst open hematoma, subcapsular hematoma, and you can have grade 4 when you start having damage to the vasculature. Now, in these, there is no damage to the direct vasculature. 1, 2, and 3, there is no damage at the hilum, but 4 and 5 is a hilar injury, and that's why in 5 it becomes a total devascularization of the spleen. That creates a problem. Now, when you talk about the splenic trauma symptoms, mechanisms, number one, it could be a blunt, seen in 33% of patients, abdominal blunt injury. It could be a penetrating type of trauma. It could be explosive trauma, right? Like, for example, a shrapnel wound, or you got a large blast. Now, three typical presentations of splenic trauma. The first is the patient comes to you and goes into shock and keeps on progressing into hemorrhagic shock, and you can't save the patient, or you try to save the patient. That basically indicates that the bleeding is continuing persistently, uninterrupted. The second, a patient who came to you in shock, you gave this patient proper therapy, he recovered, and then again went back into shock, and that was a reactionary hemorrhage. Why? Because there was a temporary cessation of bleeding, and then suddenly the bleeding reoccurred again. The third is the most fortunate patient who's got a mild degree of shock with gradual recovery. Now, injury is self-contained by hematoma pressure or greatomental migration or spontaneous clot, and these are the most fortunate patients where no treatment is required, right? Now, when you do a clinical assessment of patient with splenic trauma, you're looking at a history regarding the mode and site of trauma. That is very important. You have to look where is the site of injury. This patient will usually complain of left-sided chest pain, pleural signs may be present, refraction may be present, abdominal pain localized to the left upper quadrant, and later possibly becoming generalized when the patient has got a generalized hemoperitoneum. Left-sided shoulder pain, described as a Kehr's sign, is an uncommon finding, but if it is there, it is because your blood is now irritating the undersurface of the diaphragm on the left side, which is the diaphragmatic pleura, and it is a parietal pleura, so it is painful. So you get a left shoulder sign pain. Or you can have features of cardiovascular decompensation depending upon the degree of bleed that you have, right? The signs, number one, balances sign, which is dullness to percussion in the left flank, the left upper. Hello, hello,
Yes, sir.
hello. Okay, so I will again lost. I'm sorry, there's something wrong with the connection today. I'll take care next time. So when you talk about the balances sign, so balances sign is when you got fluid in the abdomen. This is blood there. So you do a shifting dullness on the left side. Now you will not find any shifting dullness on the left side, but when you do the same in the same patient, when you do a shifting dullness on the right side, you will find a shifting dullness positive. And the explanation is very simple. The blood has clotted on the left side around the spleen, so the shifting dullness will be absent on the left side. It will be positive on the right side. That is the balances sign. You will find evidence of flank bruising. You will find a seat belt sign, and you will find a peritoneal tenderness and guarding. Right. So all these will be there in a splenic trauma. The diagnosis is done on the basis of a E-FAST. Now, what is the E-FAST examination? A FAST technique refers to focused abdominal sonar for trauma. That means a focused abdominal ultrasound for trauma. That is FAST. Now, when you compare or when you include the thoracic cavity and the pericardium, that is known as a extended FAST. So E-FAST is an extended FAST, which is nothing but a focused abdominal ultrasound scan done especially for trauma. And why is it important? Why is it significant? Because it can identify even amount of collection as low as 100 ml of free fluid in the abdomen with 90% sensitivity, which is a very big sensitivity. Okay, the second thing is a CT scan, which is the gold standard and should be done with the intravenous contrast, and it would be indicated only in those patients who are hemodynamically stable. If the patient is not stable or he has not been stabilized, you cannot do a CT scan. There, a E-FAST examination would be the preferred method. So with CT scan, why is the gold standard? Why is it a gold standard? Number one, it can grade your splenic injury. It will tell you it's grade 1, 2, 3, 4, 5, whatever. Assessment of other organs can be done at the same time. It tells you, look, your colon is also injured, your stomach has been injured, the diaphragm has been injured. All that information cannot be gained by E-FAST. That will be gained by ECT. And it can also tell you where the hematoma inside the spleen is subcapsular or intraparenchymal. Why? Because subcapsular hematoma is likely to undergo rupture at a later point in time, so you have to be careful. The third investigation is a Doppler ultrasound and a contrast enhanced ultrasound, and useful to evaluate the spleen vasculature, especially when you're talking about a high-level injury. Now, the treatment principles of splenic trauma is simple in one line: preserve the spleen. Preserve the spleen. Conservative management by monitoring it closely. It is very important. Cardiovascular support to be given, blood transfusion, antibiotic coverage, proper rest of the patient, and treat the associated injuries like chest or other abdominal organs. If this is possible, that is the best scenario for the patient. But as I said earlier, there were two other kinds of presentations. One, where the patient is rapidly going downhill, 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 downhill. That is the patient who needs urgent intervention. The second group of patient who had come to you, you stabilize the patient, and 24 hours down the line, suddenly you find the patient has gone down again. That is the second patient who requires intervention. The first, as I said, the third one was, I said, was the most fortunate, who comes with mild symptoms and progresses just like that and goes back home. So in those cases where you have to intervene, a preference should be given to a laparoscopic intervention rather than to open intervention as of today. That is the today's view. Initially, it was a open intervention. So when you're going in for a laparoscopic intervention, you have to go in for trying to preserve again. So whenever any surgical intervention is done, again, the principle is the same: conservation. So here now we talk about conservative intervention and conservative surgery. So in one case, you may be able to do a conservative embolization of a splenic artery. That would be one option available. I'm not going to go to the details of that, but these are the options available. The second option could be that you repair the spleen, wrap the omentum around it, what is known as a omental or mesh wrap, or a splenorrhaphy with anticoagulants. The third thing, you can do a partial splenectomy. You remove only part of it. I told you these arteries have got relatively separate vascular areas, so you can easily separate one particular area. But if you're not able to do any of these relatively conservative methods of management, then you have to go in for splenectomy. And what has been advised is that when you're doing a splenectomy, you can mash the splenic pulp once you removed it and re-implant it into the omentum. They're the best site to reimplant. Now, the initial contention was that it's going to give immunological benefit to the patient. But as of now, they have found out that the spleen that you implant inside the omentum would sustain itself. It would be there, it will live. Those splenic cells will live, but the immunological functions never appear. They're always deficient. So that means the red pulp function of the splenic area may function, but otherwise it is useless as far as the immunological function of the spleen is concerned. The other non-traumatic cause of splenic rupture, so this is the most common cause of splenic rupture. The other important cause of splenic rupture are neoplasm. It could be infectious, like for example, tropical splenomegaly. It could be inflammatory disease. It could be medication and medical treatment, post-medical treatment. It could be because of mechanical causes, iatrogenic, like for example, you're doing, let's say, a mobilization of the left splenic flexure and you manage to damage the spleen. Or you're trying to mobilize the greater curvature of the stomach, you're doing some surgery on the stomach and you damage the spleen. So that is the mechanical cause. And then of course, idiopathic, where you don't find any reason why this has happened, right? So they are non-traumatic causes. Now coming to tropical splenomegaly, and this is a very important topic for the reason that it always leads to gross splenomegaly and indeterminate origin. And it has been described from various parts of the tropical countries. That is why known as tropical splenomegaly. Other names which have been assigned to it: Bengal splenomegaly, Egyptian splenomegaly, big spleen disease in Africa, but they are all confusing terms, usually occurring in children and young adults. These present with moderate anemia, stunted growth, poor general health. The etiological factors are usually non-specific, but in those specific times, conditions where you can find them, it would be Kala Azar, malaria, schistosomiasis, but more often than not, non-specific and usually part and parcel of extrahepatic portal vein thrombosis, non-cirrhotic portal fibrosis of the liver, rarely to experience pressure of the splenic outflow, like for example, a pancreatic growth or a liver growth pressing on the splenic vein, may also be a manifestation of early undetected liver cirrhosis. The treatment of tropical splenomegaly, if it is patient with non-cirrhotic, non-portal hypertension, is simple splenectomy, lifelong anti-malarials in endemic areas. Now comes the best part, and that is one variety of tropical splenomegaly has now been renamed as hyperactive malarial syndrome. That is a part of the tropical splenomegaly, and this is separate. Why? This is specific to malarial spleen, and it is characterized by gross splenomegaly 10 centimeters or more below the costal margin, where no other cause found, elevated serum immunoglobulin, up to 2 standard deviations, clinical immunological responses to anti-malarial therapy, regression of splenomegaly by 40% by 6 months after start of therapy, and high antibody levels to the various plasmodium species, namely falciparum, vivax, and ovale. Now, these are the 5 important criteria to call a particular spleen as a hyperactive malarial syndrome. Now, this occurs because of chronic antigenic stimulation that may possibly be an important part in the development of a malarial spleen. Parasites can be found inside the splenic pulp as black dots in the RBCs. When the sections are hematoxylin and eosin stage, they can be identified. But they are never found inside the Malpighian corpuscles. Remember, Malpighian corpuscles are B cell areas inside the spleen. This hyperactive malarial syndrome, the enlargement increases during each attack of malarial pyrexia. Now, the transient increase in size is because of acute congestion resulting from accumulation of red cells filled with parasites. But these repeated attacks ultimately lead to what? Thickened stroma and induration, and that's why when you have a chronic malarial spleen, which is chronic hyperactive spleen, there is not only the acute congestion, it is also an increase of hyperplasia of immune response and increased amount of fibrosis, thickened stroma, and induration. So they all together go on to give rise to the largeness of the spleen. So in the acute attack, it is only the congestion. In the chronic malarial spleen, it is also the immune response and the hyperplastic response of a thickened stroma. Spontaneous rupture is one of the most important complications for we as surgeons when we may be called to tackle a malarial spleen, and it is to be taken as a last resort. Why? Because this is an area where it is very, very difficult to do a splenectomy. That is one. Number two, a splenectomy does not usually cure you of the hyperactive malarial syndrome, because apart from splenic manifestation, the hyperactive malarial syndrome excuse me, has got other manifestations also. So try to be conservative. If at all there is chances of inflammation, of rupture, go and do a splenic artery embolization. That may serve the purpose. But only as a last resort, go ahead and do a conservative surgery or a splenectomy. Just two terms, hypersplenism and hyposplenism, and then we finish for the day. We'll talk about the rest thing later. Hypersplenism is defined, characterized by the triad of pancytopenia, especially thrombocytopenia, usually 50,000 to 1 lakh per microliters, compensatory bone marrow hyperplasia, and splenomegaly. Remember, the triad of hypersplenism has got 3 things to it. Number one, a low thrombocyte count, low platelet below 50,000 to 1 lakh. Number two, compensatory bone marrow hyperplasia. And number 2, seen with as megakaryocytes, that will show you bone marrow hyperplasia and splenomegaly. And that you can add a fourth thing, and that is once splenectomy has been done, there is improvement. So that is the characteristic triad of hypersplenism. The types are two. Number 1, primary hypersplenism, with the cause of increased size not known. The splenomegaly is there. Secondary hypersplenism is secondary to a primary cause of splenomegaly, and then that splenomegaly undergoes hypersplenism, causes hypersplenism, like for example, cirrhosis, lymphoma, malaria, tuberculosis, various connective and inflammatory disease. Remember one thing before I proceed further: splenomegaly and hypersplenism are not synonymous. Every splenomegaly will not have hypersplenism, and every patient of hypersplenism does not need to have splenomegaly. Even a normal size spleen can have, or a mild splenomegaly can give rise to hypersplenism. The pathophysiology of hypersplenism in such spleens is more important. And why does it occur? Number 1, because of excessive immune response, excessive RBC destruction. It could be because of venous congestion. It could be because of myeloproliferation, infiltration, neoplastic proliferation. It could be a platelet pooling. I told you 90% of platelet volume is there inside the spleen. So they can all be responsible for the hypersplenism. And the clinical features: number 1, splenomegaly may or may not be there. I just now told you. Number 2, related to pancytopenia. That means you can have all features which are because of low RBC, low WBC, and most importantly, low platelet count, in the form of the patient may have pallor, fever, recurrent infections, oral ulcerations, ecchymosis, petechias, and of course, the patient may be having leg ulcers. The treatment of hypersplenism, several options are there. They can improve or correct the cytopenias attributable to hypersplenism, including you can do a total or partial splenectomy, you can do a partial splenic embolization, or you can do a surgical or transjugular transhepatic portosystemic shunting if the patient has got a congestive splenomegaly causing hypersplenism. But there's a big but to it. All these three procedures are usually not indicated for a simple patient of hypersplenism presenting with only thrombocytopenia. Why? Because just doing a splenectomy in these patients, or any of these procedures in a patient for just cytopenia, is not going to be very productive. And that is why these procedures are usually not indicated for simple cytopenias, whether it is RBC, WBC, or platelet. It is usually indicated in those patients where there is a severe cytopenia, which is although rare. And number 2, if there is the spleen, the enlarged spleen is causing problem, like for example, it is so hugely large, is causing pain. So there, the reason why you're doing splenectomy is not because of hypersplenism. You are removing that spleen because that spleen is causing problem, not because it's causing hypersplenism. See, so what I'm trying to tell you is, in a patient of hypersplenism, the role of the surgeon is very, very, very limited for we as surgeons, right? Coming to the opposite end of the spectrum, and that is asplenism or hyposplenism. This could be anatomic or functional. Asplenism, anatomic, easily explainable, there is no spleen. Or hypersplenism, very, very small spleen, or a number of small spleens. Now, characterized by number 1, increased platelet. This is opposite to what we just now had. There was thrombocytopenia. Here you've got an increased number of platelets. You may require, you may have increased lymphocytes, monocytes, and you've got abnormal cells in the circulation which are supposed to be removed in the spleen, but the spleen is not functioning anymore. So these are there in the circulation. Like for example, siderocytes, Howell gel bodies, Pappenheimer, target cell, contractile RBCs, which were not supposed to be there in the circulation. The spleen was supposed to remove them, but the spleen is not functioning, or it is hyperfunctioning. So these are now found inside the circulation. So what is the problem with asplenism or hypersplenism? Why is we worried about this condition? Because there's a higher risk of pneumococcal overwhelming post-splenectomy sepsis or opportunistic post-splenectomy infection, OPSS or OPSI, especially with encapsulated bacteria, namely the pneumococcal. And these severe infection could be there apart from other encapsulated bacteria, protozoa. There's a higher risk for vascular, autoimmune, and thrombotic diseases, and there's a higher risk for developing solid tumors. The causes, most important, post-splenectomy, remove the spleen. This patient is asplenic now. It was removed for trauma, so whatever reason, right? Or there's a functional hyposplenism as seen most commonly in two important diseases, sickle cell anemia and celiac disease. The other diseases where you can find a decreased function of spleen could be blood diseases like thalassemias, lymphoproliferative diseases, inflammatory bowel disease, especially ulcerative colitis, thyrotoxicosis, and prolonged steroid administration. The other group of patients where you can get a functional hyposplenism could be bone marrow transplantation, where you have irradiated the spleen. So the spleen is irradiated, no function there. Or chronic graft versus host reaction. Or congenital asplenia, the spleen is simply not there. So in all these cases, there is a tendency for hyposplenism. The clinical feature, the spleen may or may not be palpable, usually not. Diagnosis, you find the pitted RBCs. Remember, the pitting function is no longer there. So you find these pitted RBCs. The radioisotopic scan with a 99 technetium label radiocolloid will show decreased levels of isotopic uptake, tells you that the spleen is not functioning. And the ultrasound, the CT MRI further helps you. The main treatment of hyposplenism is only two: immunize and prophylact. Immunize against what? Against streptococcus pneumoniae, meningococcal, influenza type B. When you're doing a pneumococcal vaccine, remember one thing: the conjugate vaccine is to be preferred over polysaccharide vaccine. I've written it down, just read it up. Antibiotic prophylaxis is important, especially in those patients where there's a risk of pneumococcal infection, right? And these are with the help of oral phenoxymethylpenicillins or better macrolides, that means azithromycin and clarithromycin, right? Just one last slide. And how do you find the spleen portal hypertension? The spleen portal hypertension shows, number one, hypertrophy. We all know that. The capsule is thickened. We know that. Massive splenomegaly. We know that. Apart from that, what else we find is a fibrotic malfeasance body, sidrotic pinhead nodules in the red pulp, which organize hemorrhages with yellowish center, also known as gamma Gandy body. So that's the typical spleen for a portal hypertension. I think we'll finish here. Next time we'll deal with the part 2 of this lecture, and that is spleen part 2. Thank you for your time. If you have any questions, you can get back at me. Thank you.